everyone. We want to welcome you all to ALS Canada's 2026 webinar series. My name is Emily Moffat. I am the National Community Lead with the ALS Society of Canada. Today, our focus is on genetics and ALS. We are joined by a panel of wonderful presenters who will be providing helpful information surrounding how genetics play a role in ALS, discussing genetic testing and what to expect from genetic testing or genetic counseling, as well as highlighting credible resources and supports available to assist with navigating genetic information. As well, one of our very own community members will be sharing her experience and perspective navigating SOD1 ALS within her family. So each panelist will have the opportunity to present, and at the end of all of the presentations, we will open for questions. So please feel free to put your questions in the chat, and at the very end, we will get to them. So to kick off these presentations, I would like to introduce our first presenter, Paula Trefiak. Paula is one of ALS Canada's community ambassadors and will be sharing her experience and perspective navigating SOD1 within her family. Over to you, Paula.
Thank you so much, Emily. Thank you so much for having me here today. My name is Paula Trefiak. I live with SOD1 ALS, and for me, ALS has never been an abstract diagnosis or a distant possibility. It has always been the backdrop for my entire life, shaping my childhood, my education, my career choices, and my family. I grew up in a family where ALS wasn't rare. It was expected, and at least 25% of my father's family was affected. Both my son and I learned how to walk by pushing or fetching our loved ones' canes, walkers, and wheelchairs. I learned how to read by holding newspapers and for my relatives who struggled with their hands. Caregiving wasn't an event. It was our family routine. I was a toddler when I was told, very matter-of-factly, that ALS is how we grow old on my father's side, and it never occurred to me that this wasn't a normal process of aging. And at 6, I learned 2 things at once. ALS is rare, and we don't talk about it on our side of the family because doing so could lead to devastating genetic discrimination. The same year, I watched several relatives die within months of each other. That's when I first understood the devastation of ALS, not just physically, but emotionally and financially. I was 14 years old and my siblings were 12, 11, and 4 years old when my dad became visibly symptomatic with limb onset. In my first year of university, he lost the ability to walk independently. My mom worked full-time and my younger siblings were in school. And although my dad needed increased care, he only qualified for only 2 hours of home care a day. So I became the daytime caregiver, and I reduced my course load and worked evenings and weekends to afford my post-secondary education. And like so many families affected by ALS, we did everything we could to keep my dad active, engaged, and connected to his extensive volunteer commitments. And in December 2009, my father lost this battle with ALS. Growing up, ALS shaped nearly every decision I made. Career dreams like a ballet teacher, physical therapist, or dental hygienist were dismissed as a waste of time and money because I was told I wouldn't have use of my limbs long enough to make it worthwhile. I was encouraged to seek investment and make large purchases with ALS considerations in mind. And I was told not to leave the province, to stay close, to stay where people understood the disease, to stay where family can help. And this is the reality of familial ALS. You plan your life around the disease long before symptoms ever develop. In my 20s, I started noticing limb onset in myself. I brought my concerns to my physician along with my extensive family history, and for years I would be dismissed. You're too young. It's an old man's disease. There's no treatment, so you shouldn't find out. It's just perinatal stress. Give your body a few years to recover. It wasn't until 2015 when I would finally receive the referral to the neurologist. Saskatchewan didn't have an ALS specialist at the time, and in February 2016, after an EMG, I was diagnosed on the spot and referred to an ALS specialist in Calgary for a second opinion. And in May 2016, the ALS specialist in Calgary confirmed I was symptomatic. And strangely, I felt relief that I wasn't imagining things, relief that I wasn't too young or too stressed, relief that there was a real explanation. But then came the gut-wrenching realization that at least one, if not all of my children likely carried the gene. And that was the moment I made a commitment that I will do everything in my power to improve the ALS landscape for them and for every next generation. So since 2016, I have committed, that commitment has shaped my life. I participated in the phase 1B trial, the open label extension, and the special access program for tofersen Qalsody, the first gene-specific therapy for ALS. My husband and I completed the NEALS Clinical Research Learning Institute, and along with others, I helped create the Canadian version of the Canadian ALS Learning Institute. I've advocated for changes in the Canadian ALS drug approval pathways to ensure timely access. I've helped develop the Gene Hub and resources for children, and I contribute to the proposal that led to the hiring of the first Canadian ALS Genetics Counsellor, a global first actually. And I've used my trial experience to help shape new clinical trials. I serve on the ALS Scientific and Medical Advisory Committee, and I also serve on the International Alliance's PALS and CALS Advisory Committee. And I've helped establish global best practice recommendations for ALS genetic testing and counseling. And last year, I also helped develop a pitch for the Canadian National ALS Research Strategy. This is what familial ALS looks like when it becomes advocacy. So why I keep going? Well, familial ALS is not just a diagnosis, it's a legacy, one I refuse to pass down unchanged. But I can't rewrite my family's past, but I can shape the future for my children, for your families, and for every person who will one day hear the words, "You carry the gene and you have ALS." My advocacy is driven by love, by lived experience, and by the belief that progress is possible, not just someday, but now. And what I want you to take away from my experience is this: advocacy is not abstract, it's not reserved for experts or professionals. It's built by people like us, people who have lived the reality, carried the weight, and refused to let our stories end there. Your voice is powerful, your lived experience is evidence, and your advocacy can shape lives, including the lives you will never meet. The ALS community needs you, the next generation needs you, and together we can build a future where this disease no longer defines how families grow old. Thank you.
Thank you, Paula, for not only sharing your experience, your family's experience, but how you navigate this diagnosis, as well as all of the initiatives you're a part of. So thank you so much for being a part of this webinar. And I know there will be questions at the end for you and people wanting to learn a little bit more about you and your experiences. So thank you.
Thanks.
All right, so next I would like to introduce Richard Lennon, the National Granting Manager from TD Bank Group. Thanks to a $265,000 donation from TD Bank Group, the ALS Society of Canada was pleased to announce Canada's first National Genetic Counsellor, Maya Benet, who we will hear from in just a few minutes. This 2-year pilot project aims to provide access to crucial services delivered through virtual care, helping individuals understand their genetic risks and navigation of potential treatment options. So please welcome Richard.
Thanks so much, Emily. And before I start, thank you, Paula, for sharing. That was incredible. I appreciate that. Okay, so good afternoon, everyone. Thank you for having me here. It's great to be here virtually. So, as mentioned, I work at TD, and at TD, our corporate citizenship work is rooted in supporting community-led solutions to real-world challenges that people are facing. We focus on initiatives that help reduce barriers to accessing care and timely support, particularly in systems that can be difficult to navigate. When it comes to ALS, access to the right support at the right time really matters. ALS Canada's National Genetic Counsellor program is one example of this kind of work. It focuses on identification, detection, and early access to care where delays can have significant lasting effects for people and their families. Beyond the access it helps enable today, this pilot program is also about testing a national approach in a thoughtful way and building understanding that can inform ALS care over time. At TD, we're proud to support initiatives like this, community-driven work that is focused on creating pathways to care where access is needed most. On a personal level, I myself am very proud to speak to you all today. My gran died from motor neuron disease when I was just a baby. Although I was too young to remember, I've heard just how rapidly her health deteriorated, and I can't help wonder how programs like this and organizations like ALS Canada could have helped. So, for me as a TD ambassador and for me as a grandson, thank you.
Thank you, Richard. And thank you for not only your inspiring words, but the support from yourself and TD Bank for the ALS community.
Happy to.
And now to our next presenter, which is our National Genetic Counselor, Maya Benet, who is making this initiative come to life. So Maya is a certified genetic counselor originally from Calgary, Alberta. She completed her master's in genetic counseling at McGill University. Since June, she has been working in the role of National Genetic Counselor based at the University of Calgary in partnership with ALS Canada. Please welcome Maya.
Great. Hi, everyone. Thank you for the introduction, Emily, and thank you for being here, Richard, and of course, Paula, for sharing your story. I think this section of the webinar has been introduced already, so I will jump right into it. The first thing that I wanted to start us off with is, why is this topic, genetics and ALS, so relevant today? And so there's many different factors that we could identify, but I just wanted to focus on these three today. And the first reason is that we have a better understanding of genetic factors contributing to ALS than ever before. I think this figure illustrates it really nicely. On the bottom, we have a timeline, and then here it's showing the number of genes that have been linked to ALS. And we can really see that over the past decade or 15 years, there's been an explosion in the number of genes discovered to be linked to ALS. Now, some of these are better understood than others, some of these are more rare than others, but overall, it's been an exponential increase in gene discovery over the past decade. I did want to highlight these three specific genes that I'll be coming back to later on in the presentation. So SOD1 or SOD1, which was the first gene linked to ALS in 1994, the gene FUS, and then the gene C9orf72, which, despite being the most common gene linked to ALS for those of your European ancestry, was only recently discovered in 2011. The second reason why this topic is so relevant today is that we now have recommendations for genetic counseling and genetic testing in ALS for the first time. So here's a screenshot of those evidence-based consensus guidelines. They're coming out of the United States. The first author, Jennifer Rogenbuck, is a genetic counselor also in the US. And there's many different recommendations in these guidelines, but the one that I really wanted to highlight is that everyone with ALS should be offered genetic testing. And the wording here of this recommendation is very intentional because the decision to have genetic testing or not is a personal one, but everyone should at least be offered the opportunity to make that decision for themselves. The last sort of factor that I want to touch on, and that you've probably heard about and just heard about from Paula, is that for the first time ever, there's a genetically targeted treatment approved for ALS linked to the gene SOD1. This is something that is very recent. You can see here, it was only approved in Canada about a year ago, and you've heard the impact that it can have on an individual's life already, but I will come back to some of the data from the clinical trial looking at tofersen or Qalsody a little bit later on in the presentation. So with all of these factors together, for someone with ALS 10 years, maybe even 5 years ago, genetics maybe wouldn't have been a part of the conversation unless they had a family history, and that really has shifted today. With this next section, I'd like to try and answer the question, is ALS genetic? You know, very often someone with ALS will say, if I don't have anyone else in my family, as far as I know, that also has ALS, is it possible that it's genetic? And this section will look into that a little bit deeper, but the short answer is it can be. I'd like to start us off with these two terms that are used very often, as well as these two statistics that are used very often, but I'd like to define them with how I'll be using them in this presentation. So when we think of sporadic ALS, that really just means an individual doesn't have anyone else in their family with ALS as far as they know. And that's the majority of people with ALS. On the other hand, when we're talking about familial ALS, that just means that there's other people in the family that also had ALS or related conditions. I will just note that there's been a little bit of debate as to how these terms are used or if they're even accurate or should be used anymore, but for purposes of the presentation today, this is how I'll be using. Okay. One thing that I really wanted to highlight is that familial ALS is not necessarily genetic. A better way to say that would be there's not necessarily always an identifiable genetic cause. And on the flip side, sporadic ALS is not necessarily non-genetic. I like this figure to illustrate this concept. So the bigger pie chart is meant to represent individuals with sporadic ALS, again, the majority of people, and then the smaller pie chart to represent individuals that do have a family history of ALS. If we zoom in or focus on this bigger pie chart, we can see that for most individuals that have sporadic ALS, there isn't a genetic cause that's identified. So that's the majority of people with sporadic ALS. However, about 10 to 15% of individuals with sporadic ALS actually do have a genetic cause or contribution to their ALS. Here it's broken down a little bit further by gene as well. But because of this is why genetic testing should be offered to everyone and not based on someone's family history. On the other side, if someone has a family history or familial ALS, there's 70% of the time a genetic cause or contribution that is identified, again, broken down by gene here. You will notice, however, that there's some individuals with familial ALS where we're suspicious of a genetic contribution where it's not identified. And there's a few different reasons for that. The first one is it could be that it's a gene that hasn't been linked to ALS yet, it hasn't been discovered. Or it could be that it's a little more complex than that, that there's smaller genetic risk factors that we don't understand very well, in combination with smaller environmental risk factors that we again don't understand very well. And it's the combination of these smaller factors that are showing up in the family that are harder to identify. So if we take these two numbers together, overall, we can say that about 15 to 20% of individuals with ALS will have genetic ALS. So here's just a summary of an answer to that question here. Again, most of the time, ALS is not genetic, but 15 to 20% of the time it can be. And this is more likely if it's familial ALS versus sporadic ALS. Okay. Now that I've set the scene a little bit, I want to just go into what even is a genetic test, what is it looking at, and some important terms in genetics. So to quickly review here, our bodies are made up of billions and billions of cells, and every single cell contains our DNA or our genetic information. This DNA is packaged in structures that we call chromosomes, and if you were to zoom into a chromosome, you would actually see the genetic code, which is the series of letters that gives the body the information to be able to grow, develop, and function properly. When we're talking about a gene, we're really just talking about a specific section of this genetic code that gives specific information. And so genes have names, like SOD1 is the name of a gene. We also have 2 copies of every single gene, 1 copy that was inherited from each biological parent. A genetic test, which usually is a blood sample, it can also be a cheek swab. What a genetic test does is it takes a sample of someone's DNA And it essentially reads that genetic code to see if there are any changes in the letters. We call those changes variants. This, again, is another way that I like to illustrate this. So if we picture, this sentence similarly to an information that the genetic code might give. So, the genetic code doesn't make nice sentences like these, but just to visualize, we can see that if the letter H is replaced by a different letter, it's repeated or is deleted, that changes the information given by that sentence. Similarly, if there's a change where the information given by the gene is different, that's what we call a pathogenic variant, and pathogenic variants cause a genetic condition. Pathogenic variants can also be called mutations or gene mutations, but again, we call them variants or pathogenic variants. Sometimes it's a little bit less clear. Again, going back to our sentence example here, here we can see that the change here with the B, it's a little bit less clear to know exactly what that does to the meaning of the sentence. And similarly, in the genetic code, there can sometimes be variants of uncertain significance where there is a change in the genetic code, but it's not as clear what the impact of that change is. The reason I'm mentioning these is because this helps us understand what the results of a genetic test might be. So if someone with ALS has a blood draw or does a cheek swab, here are the possible results that might come out of that test. The first result, a negative result, essentially means that the genetic code of these genes was looked at and there weren't any variants identified, so a genetic cause for that person's ALS was not identified. An uncertain or indeterminate result means that a variant of uncertain significance was identified, and this is generally not considered to be genetic ALS. And then lastly, there can be a positive result, which means that a pathogenic variant was identified and usually means that that person has genetic ALS. There's many different inheritance patterns type in genetics. So when a pathogenic variant is identified in an individual, we're not just thinking about that individual, we're also thinking about what it means for other family members. And so the most common inheritance pattern in ALS is what we call autosomal dominant inheritance. And what that means is that having a pathogenic variant shown here in the diagram in one of the two copies of a gene is enough for symptoms to develop. This type of inheritance pattern can also be seen in other conditions like Huntington's disease, for example. On the other side, autosomal recessive inheritance just means that having a pathogenic variant on one of the two copies isn't enough. And for someone to have symptoms, they actually need a pathogenic variant on both copies of the gene. Autosomal recessive inheritance can be seen in classic conditions, for example, like cystic fibrosis. With autosomal dominant inheritance, so again, if a pathogenic variant is identified, first-degree relatives like children and siblings have a 50% probability of also having inherited that same pathogenic variant. In these situations, most often, the pathogenic variant is actually inherited from one of the two parents. And so we also think about what it means for extended family members, which side of the family might this have come from. And then the last two sort of definitions that are important to mention when we're thinking about genetics and ALS, the first one is penetrance, which essentially means disease likelihood. If an individual has a pathogenic variant in a gene linked to ALS, what is the probability that they'll actually develop ALS? And most often, it's incomplete penetrance, meaning that it's not all of the time that a person will develop ALS. And then the last term that I wanted to define here is variability. And so that means that if we were to take 10 individuals with the same pathogenic variant in the same gene, their symptoms would look different. And that's true even for individuals in the same family. The age of onset or the type of ALS that they have would look different even if they carry the same pathogenic variant. That was a little bit more focused on the definitions here. This next section will look at some of the common genes that I had mentioned at the beginning of the presentation. The first one that I already alluded to is C9orf72, and 10 to 13% of people with ALS will have a variant in this gene. And as I mentioned, it's the most common single gene cause of ALS in those of European ancestry. I'm bringing it back to this diagram, but just focusing on a different part of it. So here for both C9orf72 is highlighted in blue. We can see that it does make up the majority of both familial ALS and sporadic ALS in this figure. C9orf72 has autosomal dominant inheritance as well as incomplete penetrance. And in terms of treatments, it has been this specific gene an interest as a therapeutic target. There have been clinical trials in recent years that were inconclusive, but there is still interest in this gene in the development of targeted therapies. One other thing to mention about this gene is that individuals that have a pathogenic variant in C9orf72 can either develop ALS or frontotemporal dementia, or sometimes more rare, they can develop both. And so this brings up an important point that there is a genetic link between ALS and a specific type of dementia called frontotemporal dementia. And so this is the spectrum, or this genetic overlap, is illustrated in this figure, where there are some genes where we're really only seeing these genes associated with ALS. There's some genes that are really only associated with FTD, and there are some genes that can be associated with both. The second gene that I wanted to go over, again, one that you've heard about, is SOD1. 2 to 4% of people with ALS approximately will have a variant in SOD1. It also has autosomal dominant inheritance for the most part, although certain variants can have autosomal recessive inheritance. And then different variants can give us information, for example, about what to expect, or the penetrance as well is variable with different variants. Okay. You've already heard about Qalsody or tofersen, which is the targeted therapy specific to SOD1. I did want to come back to this figure. Again, this is from a very recent paper, February 2026, following the clinical trial looking at this specific treatment. And so here, this one specific graph, they have other figures, but this one graph is showing in red the participants of the clinical trial that started on tofersen right away. And then in the black dots, it's the participants where at first, for the first 28 weeks, they received a placebo, so they weren't receiving the treatment. And after 28 weeks here, they actually started on tofersen, so they had a delayed start. This graph is a representation of neurofilament levels, and neurofilament is a biomarker of neuron degeneration. And so we can really see, especially in the first 28 weeks, that the participants who were on tofersen, that level of NFL dropped, while the participants who were not on tofersen, that level increased. Okay. Perfect. The last gene that I wanted to go over is FUS, which is found in about 1% of people with ALS. Again, it's largely autosomal dominant inheritance with this gene, as well as incomplete penetrance, but there is considerable variability. Interestingly, this gene is associated with juvenile ALS, which is ALS that has an onset before 25 years of age. The reason that I wanted to mention this gene specifically is that there is an ongoing clinical trial where they're evaluating this treatment targeted to FUS, and it has a similar mechanism to tofersen Qalsody. And so this is the study. You can see that it's active but not recruiting, so we're currently awaiting for the results of this clinical trial. Okay. The last major section that I wanted to include in this presentation is genetic counseling in ALS. Genetic counselors are healthcare providers specialized in medical genetics. So when you go to a genetic counseling appointment, it really is a discussion with a genetic counselor about potential testing options and support in that decision-making process. Importantly, genetic counseling is not genetic testing. So it's still really valuable to have an appointment with a genetic counselor, even if testing might not be offered, or if that person doesn't think they're interested in testing, having that discussion can be really valuable. Here's an example of the topics that might be covered during a pre-test genetic counseling appointment. So a genetic counseling appointment for someone that has ALS, and we're discussing the option of genetic testing. So the first thing, usually we would ask about the family history, and that would be pretty detailed, asking about family members, and we would interpret that family history kind of to say, well, what is the probability of this being genetic if we had to interpret that history? Then, of course, we would go through the different options of the genetic test, the possible results, and then the implications and limitations of testing for that individual and their relatives. So that's kind of the topics that would be covered during a genetic counseling appointment. Here are some factors, or why might someone consider genetic testing? And most of these apply if an individual then has a positive genetic test result. But having a positive genetic test result can provide diagnostic closure in the sense that, having a negative genetic test result doesn't mean that that person doesn't have ALS. We reviewed that the majority of the time ALS is not genetic. But on the other hand, having a variant in an ALS gene can provide additional support for that ALS diagnosis. As well, I've kind of hinted at the fact that with different genes, we may be able to give certain information about what to expect. If it's a gene that has been seen linked to FTD, or information about that specific variant based on what was seen in other individuals with that variant. But of course, there always remains that aspect of variability where we would never be able to predict exactly what would happen for an individual. We've also already alluded to the fact that there might be different treatment options depending on someone's genetic test result, as well as eligibility for clinical trials that are targeted to a specific gene. Information for family members about their own likelihood of developing ALS, and this is true regardless of the genetic test results, that would give information to family members. And then lastly, in terms of personal impact, I think a question that I hear a lot is, why did I develop ALS? And most of the time there isn't a good answer to that, but in situations where maybe there is a genetic contribution, that helps to answer part of the why. This is an example. Again, this looks pretty familiar, but once that genetic test result, here are the points that we might cover during a post-test genetic counseling appointment. So for a negative result, again, that means a genetic cause wasn't identified. We would want to think about the limitations of testing. So how many genes were included in the genetic test, maybe how long ago the genetic test was done, things like that. For an uncertain result, we would want to see if there are any additional investigations that might help us to interpret that result better. But usually with an uncertain result, we just give it time for there to be additional evidence in research to be able to better interpret that result. And then lastly, I kind of gave an idea of what information an individual might get with a positive result, so I won't go through these. But I wanted to come back to this, what can it mean for family members? And so when a pathogenic variant is identified in an individual with ALS, their family members who don't have symptoms may have the ability to have predictive genetic testing. And so again, predictive genetic testing is testing for someone who doesn't have symptoms. And essentially, it's predicting if they have inherited that same pathogenic variant, if they are at a higher risk of developing ALS, but it can't tell us if that person will develop ALS, when or how symptoms will show up. In general, predictive testing is not offered if it's an uncertain result or if there's low penetrance of that variant or that gene. It is generally not offered to minors if it's a condition that's expected to show up many years later. Okay. As you can imagine, the decision to have predictive genetic testing can be a really difficult one. Some people want to know that information and some people don't want to know that information. And so it's a very personal decision. But here are some different considerations about predictive genetic testing. So When we think about future planning, individuals might want to know that information in terms of family planning or their career planning or their financial goals. Individuals might think about the impact on their relationships. If there's different people in the family that have different views about this topic, if some people are interested in predictive genetic testing and others aren't, how might that impact the family dynamics or other relationships? Some people might be motivated to have that information, to be able to give that information to their children. So there's many different considerations here. Of course, psychological considerations, some people just don't want to know. Some people cope with information differently or have different levels of anxiety about different considerations. And so that plays a part in the decision. And then, many other sort of personal factors, but genetic counseling appointments for predictive testing can be really helpful to kind of support in that decision-making process. And then the last thing that I just wanted to share is a little bit more about my role. So this is a new initiative, as you've heard, and I just wanted to share how I can support people that have ALS and then families that have been affected by ALS as well. So I do provide virtual genetic counseling for people with ALS across Canada, as well as predictive genetic counseling, although in certain situations it might be better to go to the local genetics clinic, but I'm able to provide both of those. And this really works mostly right now with referrals from doctors at ALS clinics. So they will refer directly to me, and then I'm able to coordinate virtual genetic counseling appointments. And then beyond that, I also provide support, maybe with referral pathways or with different services across the country. I'm able to support in that, answer questions, kind of facilitate that part of it as well. Okay, and that was everything from me. So of course, I wanted to thank TD Bank. I wouldn't be here giving this presentation today without their support. And then wanted to thank everyone for listening. Please feel free to put your questions in the chat. We'll answer them at the end. And then if there's any questions that come up after the webinar or anything related to sort of this topic, you can email genetics@als.ca. This is a pretty recent addition. We've kind of just created this email address, but feel free to use that address. So thank you.
Thank you, Maya, for your presentation. It has been a topic that individuals have been very interested in, so thank you so much for presenting to our community today. And so I want to hand it over to our next presenter before we get into the list of questions that we have received. And so I would like to introduce Carolina Young. Carolina is ALS Canada's Manager of Research Engagement and Impact, where she leads research communications and resources for the ALS community and supports the organization's research grant program and Canadian research initiatives and events. So please welcome Carolina.
Thanks, Emily. So I'm just going to share my screen. I'm just going to wrap up the presentation by talking about some of our resources and a little bit of research landscape, and just ending with some of our efforts as well. So hopefully you can see my screen. So the first thing I wanted to talk about is kind of our resources that we offer for genetics, in addition to Maya. So we have the ALS Canada Gene Hub, which is a section of our website to provide support and resources to anyone looking for more information on ALS genetics. It really is kind of the first of its kind genetic resource, because our idea was to not only provide a lot of resources from us here at ALS Canada, but also there's so many wonderful resources across organizations worldwide that also have really good resources for genetics. So we kind of wanted to bring all of those resources together and kind of make it really easy to navigate where you're looking for more information on genetics and kind of explore everything. And it was built with lots of feedback from the community. So as you see, Paula mentioned that she also contributed to this. And we did consult clinicians, of course, genetic counselors. So it really is meant to be kind of a comprehensive source of information for you. And it really is for everyone in terms of, we cover from the very basics of ALS genetics and exploring the genes to how to access genetic testing in Canada and genetic testing considerations to kind of more research opportunities. In fact, this is all of the sections that you can find on the Gene Hub. So we do really try to provide a lot of information, and we are looking to expanding it very soon So how to provide more interactive components and a lot of more information that we could be providing. And then we also have another genetic resource for families affected by a genetic form of ALS, so made to provide guidance and support in having those initial genetic conversations within the family and especially youth. It was made with Dr. Melina Kavanaugh from Global Neuro Eye Care, who is just an expert in children and family dynamics within the context of ALS and caregiving and telediagnosis. And while most ALS and all FTD cases will develop in adulthood, understanding what a genetic result may mean can be really important for young people and children early on. And, children, they do want to be included in those conversations. And we know that they learn about genetics in school. And when they learn about ALS, it is just a Google away from kind of making that connection between, is ALS genetics? It kind of brings a lot of questions for them and within the family. So we do encourage getting the support that you need from this resource from ALS Canada, from other patient-led organizations, from peers to kind of navigate those conversations. So the resource kind of includes questions children might ask, timing, processing your own feelings, and then some information from the Gene Hub as well on basic genetics and accessing testing for young adults, etc. For other genetic resources, we do have a genetics glossary. So if you can remember some of the terms that Maya mentioned, it's here for you. And as I mentioned, just a bunch of resources in the Gene Hub from other organizations as well, including some interactive resources that you can explore. One that I did want to mention is the ALS Online Database, which is a comprehensive database kind of saying the evidence of that particular gene being linked to ALS. There's more than 40 ALS-associated genes with different evidence as of right now. So we have definite ALS genes like SOD1, C9, FUS that Maya talked about, but we also have some genes with kind of moderate evidence to low to kind of unassigned. So as more research comes out and as we get more evidence for some of these genes, this is the kind of database that we can look to. And I do want to mention as well, ALS Canada with Maya and with ALS clinicians across the country, we're working towards providing more genetic support in Canada, especially peer support. And as we do so, we do look to our peers in the legacy, which you haven't heard from them. They are a key player in the genetics, ALS, and FTD world. And we do look up to them on how we can bring more of this work to Canada. But I do want to mention them as well because they have such great resources for learning and peer support as well. So I wanted to highlight that there's a lot of genetic research happening worldwide and in Canada. And one initiative that I want to talk about is Project Mine. So with 21 countries contributing, Project Mine is the largest resource of genetic data of ALS in the world. And their main goal is to not only to find new ALS genes and kind of provide that evidence, but also they look into other areas of genetic research, such as how are genes expressed in ALS and ethnic variations within different populations. And we have supported more than 800 DNA samples from Canadians into the platform. And not only talking about Project Mine, but we are committed to global collaboration and to kind of support Canadian DNA samples where we can to other projects as well and other initiatives. And not only DNA samples, but also samples, for example, from Capture ALS, which is an observational study, and how can we incorporate that global data so researchers worldwide can go in and kind of use these DNA samples into their research to identify new genes and to kind of get more insights into genetic ALS. And over the last 10 years, ALS genetics has moved from identifying, a small number of genes over the years, ever since SOD1 gene was identified in 1993, more than 3 decades ago. And we now have a much broader understanding of ALS as a genetic influence disease, even in people without a family history, as we talked about. And discoveries are moving at a much faster pace because of these collaborative efforts. And understanding ALS genetics is what made us have a major clinical breakthrough to tofersen, which is Casdotin, which, again, as we talked about, is the first gene-targeted therapy for ALS for people living with SOD1 and ALS. And increasingly, we are seeing that Casdotin works long-term, especially if initiated early, as an early treatment to halt disease symptoms and progression, and even some people are regaining back function in a very small subset of people. But because we just need to figure out a mechanism that works like COSODI for everyone affected by ALS. And genetics can play a huge role in this. And at the same time that we are discovering new genes and kind of how to target them for clinical therapies and investigating ALS in that way, by studying people who carry a genetic variant but are not showing symptoms or did not develop ALS, there's also really exciting and important research and a lot of studies for blood that are kind of looking into how can we detect ALS before symptoms even appear, and why do some people get ALS and others don't. So kind of looking at pre-symptomatic studies, so we can understand ALS better and eventually kind of reach that state of precision medicine, so personalized treatments for everyone. There isn't currently an opportunity in Canada to participate in a pre-symptomatic study. We are pushing for those conversations, so hopefully we can have it one day. But there are opportunities that we can talk about to kind of how do we make sure those samples are also contributing, like sending Canadian samples. And then, of course, I do want to mention a clinical trial happening for COSODI, which is called ALS. But the people that are being recruited are people who have an SOD1 genetic variant, but they don't have symptoms of ALS. So again, asymptomatic or asymptomatic. And they get enrolled in the study, and as soon as this blood biomarker, which is called NFL, neurofilament light chain, sort of goes up, the levels go up, which we are now seeing that it can kind of correlate to disease start and disease progression. That individual gets put in either COSODI or a placebo group, so they don't get the drug, but they don't know it yet because it's a placebo. So with the results from this study, it's kind of really exciting because we'll find out if this stops disease altogether from starting, or how does it affect disease progression and symptoms, and all the whole effect of that, of targeting ALS before it even begins. And of course, through our research program, we have always been committed to supporting this ALS genetic world and discoveries. And in fact, we actually supported the first discovery of the SOD1 gene and how that has led to now a treatment. And then, of course, I just want to mention again that we're so glad to have Maya with funding acquired from a grant from TD Bank, and how grateful we are because Canada is the first ever country to have an ALS National Genetics Counsellor. So it really is a big feat to kind of provide that support towards increased care and of genetics. And speaking of care and other initiatives, now kind of looking into the future, we can say that ALS Canada, especially led by our amazing community service team and Maya and other experts and the research team, we are working on building a national genetic strategy that includes several components, such as a genetic Refer ALS. So if you have heard of our tool called Refer ALS, we kind of build it together with experts and clinicians to expedite diagnosis of ALS. So it is meant for both a clinician and kind of patients to advocate for that. So we're kind of building, Maya is just doing a really good job at building this genetic Refer ALS. So this resource that can kind of simplify decision around ordering genetic testing and accessing counseling and facilitating that process of information. Our team is also doing a lot of work on genetic personas to understand all the incredible nuanced situations and families across Canada, how to best support each situation, because we know that, someone may be diagnosed with ALS and may not have a family history, but they have genetic ALS, and how do they navigate that? But another family has always known they had ALS in the family. So, and how does a person from that family kind of navigate that process? Or a person in another family, a twin may want to get genetic testing, but their other twin does not, and does not want to know results. So how does they navigate access and support and testing? So there's a lot of incredible nuanced kind of situations and how we can better support everyone, and also expanding, again, our education resources, and how can we provide more community engagement, genetic ambassadors, community support. And we're also currently kind of making sure how can we improve our timely access so we can provide better information of the things that we're talking about here, of updates in genetics and news to you directly. So if you want to sign up on our Gene Hub, there's an option now to kind of stay updated on genetic ALS research and news, so you can sign up to hear from us in the future once we kind of solidify that pathway, so you can get access to, like, there's a new study in ALS genetics, and how can we get that information to you faster and timely and accurately. And then, of course, we do have a very close relationship with CAUS, which is the Canadian ALS Research Network, which is a network of clinicians and ALS clinics across the country. And they have published, with our support as well, the Canadian Best Practice Recommendations for ALS a few years ago, which truly was a big feat in kind of standardizing, providing a standard of care for ALS. And we're looking to update that with best genetic practices, due to the fact that a lot of people, including us and experts and clinicians, are pushing for offering early genetic testing for everyone with ALS, because as we have seen from Maya's presentation, sporadic does not mean non-genetic, familial does not mean genetic. So it's kind of, how can we make sure everyone gets tested, and tries to figure that out. And then, of course, we are always considering how to increase Canadian research opportunities, and how can we bring asymptomatic care here and research opportunities for those individuals, and kind of better support that. And then, of course, mental health support as well. So I think that wraps up my end of the presentation with some of the resources and our efforts. And I think we're happy to take questions now.
Amazing. Thank you so much, Carolina. And so I have gone ahead and brought everybody onto the screen because we've had a number of questions come through. So what I will go ahead and do, I will ask questions, and our panelists, please feel free to answer to the best of your ability. One thing I do want to mention, if we're unable to get to your question today, please do connect with us at communityservices@als.ca or at research@als.ca, and we will ensure to get your questions answered. All right, so for our first question, how do individuals cope if they find out they have an SOD1 mutation? They may still be healthy and young and are potentially have just started a family.
Yes, that's a good question. Thank you. I think that this answer is really personal. You know, different people have different coping strategies, but I think that this also points to the importance of having that opportunity for a genetic counseling appointment before the test is even ordered. So you're not kind of faced with the result and then having to think about what strategies work best for you to cope with this result, what you might need. You're kind of exploring that before the test is even ordered, so that you're set up well by the time that the result comes through.
I'll say, from a familial perspective, I mean, everybody's going to cope differently, right? Especially based on your experiences caring for family or whatnot. It can be very devastating. I will share, though, that, you know, my son, who is now 18, decided to pursue genetic testing a year ago. He did find out he was a gene carrier, but what's unique about his story is that he found out he's a gene carrier 3 days after tofersen Qalsody was approved by Health Canada, and he has seen the huge amounts of success that I've had on this drug. It seems to have stopped my disease progression for 6 years or 7 years and counting now. And his first comment when he got his results was, "At least I now have a treatable disease." And yeah, that just melted my heart, because that's absolutely what I wanted to hear by the time he got his results.
Thank you, Maya and Paula, for your answers. I have a few other questions regarding SOD1 specific. So next question, my father had the SOD1 variant. How would my sisters and I get connected with Maya for counseling about predictive genetic testing? We are currently asymptomatic. Would we get the referral from our family physician?
Yes, good question. For this specifically, I would encourage you to email any of the emails, you know, genetics@als.ca, research@als.ca, just because the information might be a little bit different depending on what province you're in, and if you're already connected with an ALS clinic, for example. So I would encourage you to reach out so I can give a more specific answer. We haven't gotten referrals from family doctors yet, but again, this is fairly recent, so we are figuring it out, and you know, I'll support you as best as I can. So I would encourage you to reach out directly.
Thank you. is there an advantage to undergo predictive genetic testing for the SOD1 gene? Will treatment be fast-tracked with QALSODY?
Yes, and there is, I didn't have time to mention in this presentation, but there is also an ongoing clinical trial for tofersen for individuals who don't have symptoms yet. And so that is being evaluated, and depending on the results of that clinical trial, it's possible that there are different recommendations. But I think that that can be an aspect to consider, is that, if you know that you carry this variant, or you might be followed regularly, or the symptoms might be caught earlier on. And so in the end, perhaps you would get treatment earlier. I think that is something to consider.
Thank you. What steps should I take if I have difficulty accessing genetic testing?
That's a very broad question. I think it depends. If you are someone that has ALS, if and you have access to asking that question to a neurologist, or if you are someone that has a family history, it really depends on your situation. Again, I'm sorry this isn't a really satisfying answer. I would encourage you to reach out with more details. But in general, either emailing, and then we can work through the specific steps, or asking a doctor, a neurologist, a family doctor, specifically saying, what are the next best steps, I think. But yeah, sorry, that's a pretty general answer.
And I'll say from experience, it was a matter of keep finding a doctor who is willing to give me that referral. I had to go through several before I finally found one that was willing to refer me for genetics testing, given my family history. So don't give up.
Thank you. Can your genetic test results, uncertain or unknown, change over time, and if a later genetic test is recommended?
Yes, good question. And so, yes, with uncertain results, that's kind of the thing that we want to really share, is that they don't stay uncertain forever. They're reclassified either as, yes, now we understand it better, we think that this does cause the gene to not function properly, or now that we understand it better, we actually think this is a normal variation that doesn't really impact someone's health. So with a variant of uncertain significance, an individual is encouraged to reach out periodically every 3 to 5 years until essentially it gets reclassified. I don't think there would necessarily be recommendations for that person to get different genetic testing, but if it gets reclassified as pathogenic, then other family members might be able to get predictive testing.
Thank you. There are a few questions surrounding the uncertain or unknown genetic results and about being retested for some new genes. So I think that answered quite a few questions, which is very appreciated. One of the other questions is, I have the C9orf72 mutation. I'm struggling with whether to tell my children, ages 20 and 23. I don't want them living their lives with this hanging over their heads. Any thoughts or advice?
Yeah, this is a difficult situation. It's understandable, that you're feeling that way. I think it's really hard to give advice, because at the end of the day, that person knows their children best, they know their family best. In general, it's recommended to share that information, again, because then they would have that option to make that decision for themselves. But I would encourage you, if you haven't had a genetic counseling appointment, that could be a really good opportunity to kind of discuss your thoughts around that, kind of strategies, or maybe role play how you might share that information. So if you had a genetic counseling appointment, reach back out just for another discussion. And if you haven't, I think it would be a good opportunity to have that discussion and that support with that.
I would definitely recommend, go for some counseling, understand, where you are in your place with your understanding of the disease, and, have the help of that counselor to come to a place where you can have a productive session with your family to explain the diagnosis. I'm very open about it, and I think knowledge is power, and I'm very glad that my children are in a place where they can talk about it from a proactive stance of wanting to help with research and wanting to make the world a better place before, they're affected. They want to make sure everything's in place before they might need that care. And so that's one way to look at this as well. But also there's a lot of things like the Capture ALS project right now where we're trying to understand, why my ALS is different from your ALS type of thing. And, the sooner we can start participating in some of that research, and they can start following us through to understand maybe what causes it, why does it get activated in us, I think the better. And that might be something proactive that might also be somewhat healing on a level for them as well. So that's things to consider.
Yeah, I mean, I would just, if you haven't already, a resource on how talking to youth about that also cover some of those points as well. And then again, peer organizations and just kind of connecting with, again, as you said, my genetic counselor and getting that support elsewhere for me is really important.
A few more questions, and you all are getting praises in the chat, which is great. Are there stats on percentage of people with ALS and FTD that is not genetic, or is ALS and FTD most often genetic?
That's a really good question, actually. Yeah, I think in general, if there is someone that has ALS and FTD, it's more likely to be genetic. I don't have specific numbers. I'm not sure if there has been a study that has looked at that specifically, but that's a really good question. So I'll look into it. But I don't know the number off the top of my head. I'm not sure if it's been looked at.
Thank you. My parent has sporadic ALS. Would you recommend I get testing to see if I am a carrier?
Yeah, good question. This is one that comes up quite often, where there's one family member that had ALS. Maybe they never had genetic testing. What does it mean for me? Truthfully, I think that you could ask your family doctor to be referred to your local genetics clinic. I think that you could explore the option of testing for you or have that discussion, but there aren't necessarily sort of a standardized approach to this, and the answer that you get might be different depending on where you are. But again, happy to kind of give you a more specific answer based on where you are if you email.
Thank you. I have two more questions. I do have SOD1, but I do not think I have had my neurofilament tested. Would there be a reason for that?
Yeah, that's a good point. I think neurofilament is pretty recent. I think in the clinical trial, they used it as sort of a marker that the study with tofersen should continue. I think that neurologists sometimes will order it, sometimes won't order it. So it's not necessarily something that you're missing, I would say. But it sometimes is included as part of the workup.
I think we're still waiting on a lot of research to explain if there is a real significance behind it. As of right now, what the data is kind of showing, I mean, for those who have had their neurofilament tested, I mean, it does go up and down constantly depending on whether you're sick or what's going on in your life. But I mean, like I said, during the study, it did show a significant drop, but even though it's dropped, it still goes up and down sometimes depending on what's happening in your life. So they don't see it as something that should be tested right now, but that may change with research as it comes about.
Yeah, and we do know increasingly that NFL has a value in clinical trials and research because they're looking at a broad subset of people, right? So it's not just one individual person and that individual NFL value from that person, because as you said, Paula, we're still understanding on how it varies, and some people with ALS may have an elevated NFL, and what does that mean? But some people with ALS may not have an elevated NFL at all. So we're still kind of understanding what that means on an individual level. So we can't really say if there's any value in capturing NFL because you don't know what that means on an individual level. Some clinics are doing just for a future research standpoint, but there is kind of a value in those clinical trials capturing because we're looking at NFL across, hundreds of people, and then we can definitely tell if there's a trend in decreasing or there's a trend at the start So there's value in clinical trials. We still don't know the proper value and what it means in an individual level.
Great, thank you. So the last question that we'll be able to get to is, there recently was a large-scale study with findings released as reported by Nature Genetics on March 30th, which looked at 200,000 people with ALS that found many new genes that could potentially be linked to ALS. How will this affect the percentage of familial versus sporadic?
Yes, great question. And someone who's on top of it with the new research coming out. I think this is a really good example of we're constantly getting new knowledge about the genetics underlying ALS. And this is an example of a paper with a really large data set. And so I think that these numbers that we have now of, 15 to 20% of ALS is genetic is the number we have today, but that number will continue to shift, and who knows what the conversation will be like in 10 years. Likely it'll be more, and studies like that definitely help contribute to that knowledge.
Yeah, and that study specifically, they examined Project Mind data, which I covered in my presentation and they have uncovered new ALS genes, and they do make the case and provide kind of evidence that, instead of 20% of ALS cases being genetic, they say it's 25, but I don't think they provide a lot of detail into the percentage of familial versus sporadic. I think there still needs to be more validation of that data and kind of looking into those differences and into the new genes that were discovered, into the new evidence to kind of back that up properly and kind of transfer those genes to like ALS databases. So I think there's still a little bit more research towards that, but it is really exciting that we are discovering new ALS genes and kind of seeing how that percentage of identifiable variants are increasing.
Great. I'm just going through. There have been so many questions, and if we have been unable to get to your question, or if things have come up now that you have listened to our presenters, please don't hesitate to reach out to us where we can provide more information. So on behalf of ALS Canada, I would like to thank all of our panelists for taking the time to join us today and really going in depth surrounding genetics and ALS and providing not only information, but resources available. There have been so many questions, and it has been really great to have these types of conversations. And so we will have this session's recording available on ALS Canada's YouTube page for people to watch back or to be able to access if you weren't able to join us today. If there are any additional questions, please do not hesitate to reach out to community services at als.ca or research@als.ca, and we will ensure that resources and support are provided and your questions are answered by the best individual. So I want to again thank not only our panelists, but everyone who was able to join us today for being able to be a part of this topic. And if there's any questions, please don't hesitate to reach out. Thank you, everyone, and have a great rest of your day.
Thank you, everyone.
Bye, everyone. Thank you.